Kevin, your organization is a big aggregator of multiple data sources. Tell us more.
Yeah, we are very data hungry. We believe that there is no limit to the amount of data that is helpful. The key is turning all data into something that is helpful. So all of the data can be there. You'll say, are we inundated? I'd say, no, I still want more data. And I'd like easier access to data in more normalized and standardized ways. I love FHIR, and I love EHRs that say they are compliant with FHIR, but most of them, when you go under the hood, they're not. And I'd love claims data to be more normalized, and CMS is doing some great things on interoperability around that, and the BCDA is wonderful, but basically no one else uses it other than CMS. And so there's a lot of limitations even to being able to get access to the data. What we've done is we've built our platform to be able to ingest all of those different data sources, and then we use that as the foundation upon which we start building insights. When we go to then build those insights, that's the process of using the clinical teams, of getting the feedback, of getting all of those different pieces. We've built our entire platform to leverage clinical feedback as the gold standard answer to the question of, does something exist? We don't guess. We surface insights to physicians. We get feedback from physicians. Every time they say yes and no to a single thing that we bring in front of them as an insight, that feeds the model's performance itself. So all of our models are not tuned against historical claims data, which, as we all know, is at best 3 months lagging and not predictive by definition. Instead, we trust clinicians in the field who are actively seeing those patients, who are actively working with those patients. That feedback is ultimately the ground truth for how we build our models. I think one of the questions and comments that came up as well is, are you inundated with data? More often than not, what we find is our models improve when we do feature modeling and feature analysis and different work on our models when we remove data from the data models. You can add as many features as you want, and what happens is the significance of that individual feature gets lower and lower and lower, so the predictive value of it becomes lower. More important often is removing data from the model feature sets to actively tune for the right signals that are impactful, that are the signals, right? The temperature of your foot, that is so important in that setting, but then if I'm in a totally different setting, that could be a useless feature. And so a lot of the work is bringing in the data, but then leveraging the data appropriately in the right context and making sure that the data that you're using is ultimately validated clinically in the right setting, and that I'm not a doctor, I have no clinical experience. I shouldn't be saying whether something's better or not. The doctors are, right? We really need to empower and trust our physicians when they're handling all of the data. And that's how we've tried to build our technology and what we've done, and where we continue to say, more data is good. It just has to be handled appropriately and built appropriately.
And, my doctoral work was in the emotive cognitive layer of artificial and actual intelligence. So how do patient-provider interactions affect the outcomes? And the conclusion is that 37% of variation in outcomes is directly attributable to whether the doctor believes the patient and the patient believes the doctor. It's essential and integral to our model at DecisionRx, and we won't take a client unless we can guarantee 360-degree visibility and 100% communication with everybody in the provider care team, because you just can't guarantee capture. About the 72-year-old skier that pulls a quad tendon when they're skiing or something like that, or the elderly fall victim. Those are the ones that come not from deductive logic necessarily, but from informed deductive logic that AI brings, big data and artificial intelligence. So I want to come back to your original question, though. None of them are effective unless a human being is actually meeting with another human being at the intersection to say, do you believe me? Can I believe you when you say you're going to take your medication?
One of the things I heard, I guess sort of 50-50 split on this panel, is the role of AI. Jim talked about it. You've talked about it to some degree. Jon, is there a role for AI in your business?
I think so. I mean, you get, when you have all these disparate now ports of data coming in, you're trying to figure out what is that next best action, right? An MBA framework. That is a brilliant tool to be able to describe is it this right call type at this right time? Is it the right framework to use on that call type? Is it bringing in the health plan now because they have the infrastructure? But now with all this data, you have to make meaningful inferences and guided workflows. And what we're finding is that is a great use of AI. It doesn't have to be too fancy, but it's just building that framework so you know what is that next best action to do, especially when the patient's right here on the phone with you in that moment. Like, again, how to best run that call and where to get that patient as you're pulling in data, the context from that call, and of course, any of the physiologic parameters, or even, for us, patient-reported outcomes, which we get before clearly claims data. Any of that gave context on their trajectory and where they're headed.
Terri, you have a role for AI, do you think?
I have evolved my thinking on this so much lately, where I've really become bullish on the degree to which AI can really successfully engage with people in ways that I think sometimes is better than even very experienced clinicians. And so around goals of care conversations and things like that, normally you would think, no, no, you need to be trained or whatever. Well, I've seen examples where the AI bot is picking up cues of things to help time the goals of care conversations with when it should be sort of applied to decision making. So if you're just talking about goals with people, but then they don't know that they should be thinking about those goals if they're talking about going on their next chemotherapy treatment that has little likelihood of helping them, but potentially very, very burdensome. But they had this discussion that their goal was not to have to go back in the hospital and limit as side effects and all those kinds of things. I mean, I think AI can prompt and help people to start integrating some of their goals with their decisions when clinicians may not be around to be able to do it. I also think they can screen for symptoms and other kinds of needs and use them as alerts for people then to come and help solve whatever those priority needs are. And last, I think we're going to be moving into the ability for medbots or whoever to be able to actually scan records and help to prompt what kinds of questions should be asked on the next visit, as well as assisting in care planning. And honestly, I don't want to put down like my fellow clinicians, but I have seen really good clinicians who are not that great at care planning, really thinking about what the priority needs of the patients are and what steps need to be taken in order to prevent them from getting hospitalized or whatever. They're sort of siloed thinking, and I think that AI is going to be able to help kind of take what's going on and help to identify what some of these key priorities are, and even help to identify what some of the interventions or education or training with patients and caregivers could be as a next step.